I am Dr. Ruth Michaelis, and I'm a family physician at Health Point Community Health Center in Washington State. I am also faculty at the A.T. Still University School of Osteopathic Medicine in Arizona, which embeds students in community health centers for their last 3 years of medical school. The patient experience has eclipsed many other measures in our quest for healthcare quality improvement, as it is linked to both healthcare outcomes and patient satisfaction. Healthcare leaders are prioritizing the patient experience through laws like the Affordable Care Act to change the direction of reimbursement from quantity to quality. Patients have long filled out patient satisfaction surveys, which actually do correspond to places that provide better quality of care, not just to patients recommending their doctor to family and friends. But patient surveys often just allow us to compare services against our goals and don't always provide direction on how to improve. In order to improve the patient experience, we have to continuously identify and subsequently resolve issues by addressing fundamental processes within the organization. One of the tools with which to address these processes is through lean methodology. Here are the scholars' projects focusing on improving patient experiences.
This project is to observe new patient visits from start to finish. The objective is to identify areas of waste according to the waste categories set forth by Lean Management Guidelines created by Toyota Motor Company. The hypothesis is that non-English speaking visits where interpretation is needed will take much longer than English speaking visits. The goal of this project is to ultimately improve new patient interaction as to increase quality of care, patient satisfaction, and efficiency. New patients were approached at check-in, informed of the project, and verbally consented to being observed. The total number of subjects observed was 8. 6 of these patients spoke English at their visit and 2 used an interpreter. The timer started at the moment of check-in and stopped the moment checkout activities were completed. The range, mode, median, and mean time were obtained on 10 categories. These categories included check-in procedures, wait time, time with medical assistants, time with providers, time in the lab, and time at checkout. Contrary to the initial hypothesis, non-English speaking visits were not longer than English speaking. However, non-English speaking visits had longer face time with providers than English speaking. More research is needed to determine the source of the delays. Better coordination is needed between caseworkers, Department of Public Health, and Health Point clinics. Standardizing the check-in process to include pharmacy information, medical record release forms, and patient disability forms can streamline the visit and set reasonable expectations for the visit as well.
Hi everyone, my name is Keanu Hill. I'm a medical student at Sophie Davis School of Biomedical Education, and today I'll be talking to you about my project, which is called Patient Satisfaction, an analytical look at waiting room times. My site was Healthcare Center for the Homeless, also known as Orange Blossom Family Health in Orlando, Florida. Um, to start off, the objectives for my study was to evaluate patient perception of exam room and wait room times, and to determine how these affect satisfaction with the provider overall. So I did this by giving out a survey in the waiting room and the exam rooms to 194 returning patients of the health center, 18 and over. I also did a patient follow with about 6 patients, in which I recorded interactions from the moment they checked in to the checkout. And I also had some pretty interesting findings based on this method. So my main findings were that majority of patients spend more than an hour in the waiting room and between 11 and 20 minutes in the exam room. And this percentage was about 40% of the total population in both situations. I also found that about two-thirds of patients are not informed about their weight, which means that, well, if they had to wait about 2 hours in the waiting room, there was no one telling them exactly what was going on, which can be very frustrating. I've also found that a little over half the study population prefers going in the waiting room. I expected a higher percentage because I read several studies which indicated that patients do tend to prefer to wait in the waiting room, but in this situation, it was only about 51% compared to 48% that preferred waiting in the exam room. My last finding was that despite long waits, patients do believe that their health care concerns are being taken care of and that their provider takes his or her time with them in the exam room, which was ultimately what I wanted to test, and it was a positive finding, so patients are generally satisfied. Based on this, I have four recommendations. Um, First, there should be a diabetes education center implemented in the waiting room so that patients have an outlet to distract themselves from the long wait and can also benefit by learning some healthy life habits. I also suggested that they should have the MAs learn how to work the EHR better so as to reduce the long wait times that the provider spends working the EHR and extend the amount of times that the provider spends face to face with the patient. I suggested a queue that keeps patient informed so they know what's going on with their wait and they know if their provider is falling behind schedule. And lastly, based on popular requests, I suggested that there should be healthy snacks such as individually wrapped fruits in the waiting room for patients to benefit from. Considering that this health center serves a very large homeless population, we don't know exactly when the last time was that some of these patients had a healthy meal. So I think it would be very beneficial for them to have something else, such as fruits, available for them to eat and snack home while they wait. And that's all for my presentation. I hope you guys enjoyed it and thank you for the opportunity.
This study evaluates the knowledge, attitudes, and practices of patients at Orange Blossom Family Health regarding colorectal cancer and cancer screening, specifically the fecal occult blood test, FOBT. The aim was to better understand patients' perceptions of colorectal cancer and related health beliefs, and determine significant associations between patient characteristics, their medical history, and their knowledge, attitudes, and practices. By identifying specific factors that may affect patients' behaviors, we can understand how low colorectal cancer screening rates exist at the clinic, which are currently under 20%. The survey was developed based on the health belief model, and it was given to all established patients between 50 and 75 years of age during a 2-week period in July and August. Significant findings included an average score of 65% on the knowledge questions, and only 36% of patients reported an intent to screen for colorectal cancer using FOBT. Provider recommendation of FOBT screening was associated with increased screening rates and had a greater positive impact on screening rates in distinct vulnerable populations, specifically Blacks, Hispanics, and non-English speakers. Less than 50% of patients reported physician recommendation of FOBT screening. More positive attitudes and perceptions of colorectal cancer and screening were tied to more positive physician-patient relationships and exposure to screening. If patients' knowledge and attitudes increased favorably, they were more likely to follow through with FOBT screening. Importantly, education, insurance status, and housing status had no impact on knowledge, attitudes, and practices, as well as actual FOBT screening. Based on these results, recommendations for improvement include the use of FOBT educational materials geared towards a minority, multiracial, and multi-ethnic population, one-on-one sessions on colorectal cancer and FOBT screening with a chance for patients to ask questions, focused provider training on identifying patients who are more at risk for missing FOBT screening, and integrating community-based patient navigators into the patient-centered medical home. In conclusion, the health belief model plays a vital role in colorectal cancer screening, and barriers exist beyond the sociodemographics and access to primary care and screening services. The FOBT is at no cost for patients at Orange Blossom Family Health, so there's a great role for patients as well as providers to increase the potential for this resource.
Hi, my name is Joseph Nelson, and I'm a med student at the NYU School of Medicine. The project that I embarked on this summer was building cultural competency in community health centers. It's a pilot project beginning with Eisner Pediatric and Family Medical Center in Los Angeles, California.
Hi, my name is Andrea Santos, and I was placed at Rochester Refugee Health Center in Rochester, New York. The title of my project is Addressing Mental Health Among Refugee Children. When I arrived to Rochester, I quickly realized that they had a big refugee patient population, and I was interested in mental health, support services, resources, referrals, screening tools being used specifically to refugee children. And I quickly realized that lots of this was non existent, and therefore I shifted my project to focus more on a systems level. And my objective became to highlight the importance of addressing and assessing for mental health at all primary care office visits to refugee children. The methods that I used were naturalistic observation, so shadowing a couple different providers in their clinics, and qualitative research, speaking with, interviewing the providers, as well as a social worker at the health center, a social worker at Catholic Family Health Center, which is the resettlement agency, and a therapist at Genesee Mental Health, which is where they refer some of their patients. The key findings are refugee children under the age of 14 are not being screened or assessed for mental health issues at the time of their primary care appointments. There is currently no screening tool, policy, or protocol in place to assess for mental health among refugee children. Variability and inconsistency consists among providers. There's a lack of collaboration between Genesee Mental Health and the Refugee Health Center. Catholic Family Center is currently the only center that provides specific resettlement support services to refugees. Recommendations are to establish cross-disciplinary coalitions in order to provide quality patient care by collaborating with families, schools, clinicians, and resettlement agency. Develop systems to diminish current identified barriers and challenges to provide appropriate mental health care to this patient population. Providers should agree upon and implement a set policy or protocol on how to assess or screen refugee children under the age of 14 that works for their practice best. Additional training can be provided of all clinicians through CEUs, online modules, or other web-based trainings in order for them to understand why these children are refugees, why they're leaving their countries, and the stressors that they have endured in their homeland. Also, a group of trained specialists to provide mental health services specifically to refugee children in order to also have better collaboration with the providers. Therefore, the providers may be more inclined to assess, address, and refer refugee children to this group of trained specialists. Thank you.
My name is Kawanda Swafford. I'm from the University of California, San Francisco. My site placement was through Rochester General Medical Group in Rochester, New York, and I did my project on the victimization of Bhutanese refugees living in Rochester. The objective for my study was to look at Bhutanese refugee patients over the age of 18 about violence exposure and also healthcare providers about screening practices regarding victimization. And the study was held in a primary care setting at community health centers. The methods used for this project was in a survey form. For the Bhutanese refugee patients, I gathered 11 surveys, and the survey was consisted of 8 questions inquiring about violence, safety, and support since arriving in Rochester. The provider survey consisted of 6 questions. I had about 4 providers, and the survey they completed a 6-question survey regarding screening practices for violence exposure, available resources, and if they felt refugee patients were adequately prepared for the conditions in Rochester. The key findings of my study were that a high percentage of Bhutanese refugees have experienced violence for themselves or know someone who has since of arriving in Rochester, and that include physical assaults, robbery, threats, and harassment. Also, Bhutanese refugees feel it is important for their healthcare providers to discuss violence exposure with them. Also, healthcare providers find assessing for violence exposure is critical and needed within this population. My recommendations is to simply ask patients about violence for healthcare. My recommendations is for healthcare providers to simply ask patients about violence. For example, do you feel safe where you live? Have you had any previous experiences with trauma pre or post resettlement? Why did you leave your home country? And these questions just open up the dialogue with the healthcare provider and patient, and to build that rapport and just get the story from the perspective of that patient. Also, to know available resources inside the healthcare system and also in the community. In addition to giving patients tips about how to stay safe, instructions on to definitely call 911 if they become a victim of crime. Also, to use a buddy system when they're walking in their neighborhood. And also to avoid threatening situations as far as if they see something up ahead that is dangerous, to move to the other side of the street. I learned a lot from this project, and I understand that violence should be assessed by healthcare providers in any population, but even more so for this vulnerable population, even more so for vulnerable populations, for refugee populations, which are definitely a vulnerable population. Especially that the incidence of suicide and mental illness is increased in this population.
My name is Jalea Tucker. I'm a second-year medical student at Rosalind Franklin University, Chicago Medical School, and the title of my project was The Impact of a Group Medical Visit on Anxiety, Depression, and Quality of Life for Obese and Overweight Patients. This project took place at the Anthony Jordan Health Center in Rochester, New York. The overall premise for the project was a group medical visit, which used a multidisciplinary team composed of a physician, nurse practitioner, psychiatric nurse practitioner, registered dietitian, and was supported by a licensed practical nurse as well as the PCLP scholars. The objective of my project was to evaluate the impact of this team-based group medical visit on healthy eating, physical activity, anxiety, and depression for patients at Jordan. The idea is by providing a group medical visit environment that it will provide a different sense of support for patients, and that for patients who have chronic diseases such as obesity, that it's a better way to treat their disease because it allows for more time geared towards this one specific aspect, but it uses a holistic approach, meaning psychosocial and socioeconomic aspects to treat their health. So the entire group medical visit was 12 weeks, but my project was just for the first 6 weeks of the project. I provided surveys to the patients both before they started the group medical visit and then at the 6-week mark, and measured changes in consumption of fruits and vegetables, changes in physical activity. Also had a survey, used depression screen and anxiety screen for using the PHQ-9 to screen for depression and the GAD-7 to screen for anxiety. The key findings for this program were that individuals who scored in the moderate to severe range for both anxiety and depression were actually able to decrease their survey score by one clinical category, meaning they went from a moderate or severe level to a none to mild level just within the first 6 weeks of the program, which is pretty significant. So the findings that I had were that a team-based group medical visit built upon psychosocial, environmental, and or socioeconomic issues may be effective at improving mental health as well as diet. People were able to increase their fruits and vegetables as well as their exercise. Some recommendations I have is just in terms of administrative support, so really recruiting and retaining the patients, checking them with them weekly to be able to ensure that they're able to stick with their goals and providing that other support, necessary support to help them in the best way possible. Thank you.
I set out to do this project because I was concerned about how patients felt about me, a medical trainee participating in their care. There is always the general nervousness patients feel in an examination room, but I wondered if their reservations ran deeper, and if they were withholding any information or acting any differently because I was present. Essentially, I wondered if the presence of a student negatively impacted patient visits, especially in light of the vulnerable populations I was caring for. On the opposite spectrum, first-hand experience is crucial to medical training, and the types of patients and healthcare environments a trainee is exposed to helps to define the types of medicine he or she practices as a provider. Thus, there is a dilemma. While exposing students to vulnerable populations will help to ensure a future workforce to care for such populations, was this at the expense of the current population's health? Were students another barrier to care for vulnerable populations in the here and now? Thus, I sought to examine the perspectives and attitudes of at-risk patients towards students and to define what patients prefer to discuss in the presence of students. All patients who agreed to have a student participate in their care were issued a survey after their appointment. Everyone who was asked completed their surveys, and the results were favorable. For the most part, the presence of a student did not harm vulnerable populations. Greater than 90% of patients felt comfortable or more in the presence of a student and were able to easily discuss their concerns with their physicians. Almost all patients were open to having a student present at their next appointment, regardless of their level of comfort during the medical appointment. About 1 in 5 patients prefer to have private visits, but hopefully, through education about the role and purpose of a student, and by empowering patients with the knowledge of their own rights, these refusals will decline. Because according to the numbers in the study, patients have a good experience when students participate in their care. I would like to thank the National Medical Fellowship for allowing me to conduct this study, which has helped me to learn so much about medicine and better get to know amazing medical providers and patients.